There's a rumor out there that NAMI doesn't care about children. And that's the farthest things from the truth. So all of us who are continued in NAMI for 20 years used to have children with severe emotional disturbances. Now we have young adult children with severe disabling mental illnesses. And so we've been in this a long time, and our children became adults, and so our advocacy moved on with them. And we have today what I consider is one of the most knowledgeable individuals in children's mental health issues in the United States. That's pressure, Darcy. And she has developed the NAMI Child and Adolescent Action Center. She's building coalitions with different groups in our nation's capital to develop some sort of children's mental health system that will work and respond to the needs of children, adolescents, and families. So Darcy's going to tell you about herself. She's a peach, and I'm glad she's here. Thank you.
I want to, can you hear? Is that better? Yeah, that's good. I actually have to stand near my computer, and I feel like such a nerd. The previous speakers were so incredible and wonderful with just their words, and here I am with this piece of electronics, so I apologize. And I really feel like, wow, what a tough act to follow. The most moving presentation I think I've ever seen, followed by a presentation full of hope and humor and courage, and so I'm just feeling really intimidated. And then Gary had to say that about me, which makes me feel even more intimidated. So just bear with me. I'm actually coming here from the American Academy of Child and Adolescent Psychiatry Conference in San Diego. So I feel like I've had a lot of child psychiatry on my mind lately. So I flew in here from San Diego, and I'm a little screwed up time-wise, but other than that, I'm really delighted to be here. And I want to say thank you to Gary and Sandy, who, in the broader NAMI family, I'm from the NAMI National Office, are really treasures, and we appreciate the incredible work that they do. And the incredible... leaders, and I'll tell you, in the national office, we know what's going on in Montana because of that, so I really appreciate that. So I'm really here to talk about kind of what's happening nationally, because I really have to, I'm sorry, I don't want to lose my back to people here. I really have to confess I have not studied the system in Montana, so the children's system. So I'm not here to talk specifically about Montana, although I do know a couple of things that are going on, but to really encourage, I think, some of the exciting things that we're seeing going on nationally. So what I want to do is kind of start out with a national view of what we know now. And really what we know is that the children's mental health system is in a bit of a crisis, really across the country. And that most states are really struggling to build effective systems for children and families. So I want to start out with the first slide, which, and I'm sorry, this mouse print on your handouts. I tried to fit a whole lot of information in, and I realize the font is extremely small. Hopefully you can read it better up here. In June of 2005, the National Institute of Mental Health, the federal agency that has responsibility for funding research, really is the lead federal agency on research, released a multi-state, really huge epidemiological study. And the headline for the release of the study was, "Mental illness exacts heavy toll on youth." And I think for those of us that work in child mental health, we were really happy to see the recognition that serious mental illnesses impact youth at a really young age. And I think that David Kaczynski really showed us that in talking about his brother and how at a very early age, there were some very early signs of significant distress. And so we have not historically done a very good job of identifying that. But this is language that comes actually from the NIMH release that says half of all lifetime cases of mental illnesses begin by age 14. And we thought this was a great opportunity to help educate the broader public about the fact that mental illnesses are really illnesses that impact youth. And that despite effective treatments, there are long delays, sometimes 15 to 20 years, between the onset of symptoms and the time when people of youth are identified and actually get treatment. And that we know now from solid research that's come out that an untreated mental illness for any significant period of time can lead to really more significant long-term illness. So that there is a huge incentive from the biological and physical standpoint to identify youth as early as possible and to get them into effective treatment. Just to give you an idea of the prevalence rates, we actually, in Surgeon General David Satcher, who's our former Surgeon General, he was a tremendous leader on mental health issues. And in 1999, he released a comprehensive report that really helped raise broad awareness about the impact that mental illnesses have across the lifespan. He followed that up in 2001, in January, with the release of a children's report specifically. And what it showed is that 10% of young people have a significant serious mental illness that impacts their day-to-day lives. And 20% of children and adolescents and youth have a mental illness that requires treatment, which is a really significant number. And the really troubling part of this is that in any given year, we know from research, and this has been replicated, that only about 20% of children living with mental illnesses are actually identified and receive treatment. So that's a very troubling figure. The youth suicide crisis has gotten a whole lot of attention in the last several years. And the first bullet really, I think, has a very troubling fact, and that is that suicide is the third leading cause of death in youth ages 15 to 24. More teenagers and young adults die from suicide than from cancer, heart disease, AIDS, birth defects, stroke, pneumonia, influenza, and chronic lung disease combined. That is a really powerful fact. And we know also from the Surgeon General, from the CDC and the National Strategy Report on Suicide Prevention, that about 90% of them have treatable and often undiagnosed mental illnesses. So the youth suicide crisis has really captured the attention of the nation. In 2002, almost 4,300 young people between the ages of 10 and 24 died in this country by suicide. And I actually was at a conference where someone pointed out that in 1 year, that's more people than died in 9/11 in New York. So that was very troubling, in Washington. So that was a very troubling reality. And I think another compelling case for states is to recognize the National Governors Association actually released a report on youth suicide in 2005 that showed with cost data that states spend nearly $1 billion annually on medical costs associated both with completed suicides and with attempts. So it really makes a very, very compelling case for helping to identify youth earlier and get them into effective interventions and treatments. The other concern we have is the reality that approximately half of students in the emotional disturbance category of the special education federal law either fail or drop out of school. And that's actually the highest dropout and failure rate of any disability group. The next highest is 30%, the next highest category. So we at NAMI are deeply concerned about the reality that we have a major dropout and failure rate with students that have mental illnesses. And we also know that when youth are not in school, we are very concerned about where they are. And really this leads to a really diminished opportunity to have an independent, productive adult life. The juvenile justice crisis with youth with mental illnesses has really been extraordinarily well documented. And actually there was a very recent report released by the National Center for Mental Health and Juvenile Justice in 2006. And I would very much encourage the folks that are working at the state level across systems in both mental health and child welfare and juvenile justice to take a look at that report. Because the report is wonderful. It actually lays out some model programs in many states that have addressed this issue. Some of the approaches with diversion programs. It's a really comprehensive report that was designed for state officials. But that shows that about 70% of youth in the juvenile justice system have one or more mental illnesses. A very troubling fact. And actually, it also shows that there are other studies that replicate this very same figure. So this is not just a figure that comes out of that national center. And actually, the director of that center, who came to a NAMI national meeting, Dr. Joe Picosa, indicated that he has been to many states and talked with many commissioners of juvenile justice in the various states. And he's been to their national meetings. And what they said at the last national meeting he had attended was they were asked to say what the three biggest concerns were for juvenile justice commissioners across the states. And they said mental health, mental health, mental health. They're very concerned that youth are landing in their system. They do not feel often qualified to be able to address their needs. And they know that youth don't belong there. And also what the report documents is the reality that many of these youth are nonviolent offenders. These are non-felony offenses. Many of them are status offenders. And they get tangled in the juvenile justice system because in many cases they're not getting effective treatment. And there are barriers to treatment for them. And I think, too, at least 20% of youth have serious mental illness. This includes youth that have psychosis and really very significant illnesses, and that is hardly the place that they should be. We also saw in a national report that came out that youth with mental illnesses, some as young as 8 years old, are being held in juvenile detention because there's nowhere to treat them in the community, and it is the only safe alternative of a location to put the youth. These are not youth that have any charges pending against them. They simply, communities and states simply do not have another place to put them. So it's hard to imagine a more troubling place for a young person living with a mental illness to be than engaged in the juvenile justice system. There's been actually recently, and I think it's great because there's really more national attention being paid to what we call the schoolhouse to jailhouse pipeline. I have to say that I have learned a lot about schools, and I'm going to talk to you in a couple minutes about a program that we've started. And I was told by Joyce Berlin, who some of you may know, she developed the Family Program, that we always have to go in as social anthropologists, that it's never fair of us to go in and be judgmental about any systems until we can really learn what they're facing and better understand some of the obstacles that exist for them. And so over the last year and a half, we have been talking with schools from around the country, and I have learned a huge amount about the pressures and burdens that schools are facing in terms of class size, the No Child Left Behind, the lack of adequate funding for special education services, the lack of community support for students with mental illnesses, the lack of training they get to understand mental illnesses, the real realities for schools that make me much more sympathetic to schools. Although I still want very much to hold them accountable because I think it takes a village. And we need schools to be more actively involved in these mental health concerns. But the reality is what we hear from families, and we get lots of calls from around the country, is that when schools are having a challenging time with a student, there seems to be much more a willingness to call the police. And this has disproportionately impacted, and this has been documented as well, students with disabilities, especially those with mental illnesses that may have acting out disorders and other, may have illnesses that have symptoms that include acting out more aggressive behaviors. So we are concerned, and also many school professionals we have talked with express great concern that they don't receive training in de-escalation, in behavior management, in really understanding how to address the functional needs of students that may be living with mental illnesses. The case for early intervention, I think, actually David Kaczynski said just a little while ago in the last talk, I don't know how many of you were in there, but that we as a nation really need to focus on prevention and catching things early and better understanding how to prevent much of the tragedies that we see happening in communities. And I think this is really what this is saying. And we have seen over and over research showing that we can minimize the long-term disability, that we spend less money as states and systems when we catch kids early. And I think we've operated in this mode of crisis. I mean, we wait until a child and family are in desperate need, and suddenly, that's when systems need to engage and really come in and try to help. But by then, treating the child and family are much more costly. The child's symptoms and illness are much more severe, and the family is really suffering terribly. And often what we hear is this very dramatically impacts siblings, which is another great concern we have. So a lot of really good support for the idea that we need to do a better job of early intervention. I wanted to just kind of talk a little bit about, all that to say, things are not really looking very bright out there for many children and families. Now, there are definitely bright lights that we're seeing evolving. And the good news is there's a lot of national attention to how do we reform children's mental health. And I think states are really recognizing they're spending way more than they need to on children and families because they are waiting until we get to this crisis point. We are the NAMI national office, and a lot of this is trickling down into the state and community NAMI organizations as well. As Gary said, we are working in close consultation with a number of different organizations. We are working at the national level with the Federation of Families for Children's Mental Health, with the National Mental Health Association, with the American Academy of Child and Adolescent Psychiatry, with the American Academy of Pediatrics, And so we have a broad group that we're working with, social workers, school psychologists. Many of us are working on a bill that's designed to help address the workforce shortage. We have a problem in this country with a lack of child psychiatrists, and I am quite sure in Montana that is a major issue because it disproportionately impacts rural communities and frontier communities. We have about 7,500 child psychiatrists in this country with a current and projected need of 30,000. So you can really get a sense that families are either not able to access a child psychiatrist when their child and family desperately need it, or they're being told they must wait ungodly long periods of time to access services through a child psychiatrist. And it's not uncommon for families to travel long distances to see a child psychiatrist. I had a call from a mom who had a floridly psychotic 15-year-old son who was trying to jump out of the car, and she had to drive 5 hours to get him to a hospital where there was a psychiatrist who could help treat the child. I mean, imagine what that family was going through as the mother was driving 5 hours to get her son until he desperately needed. So there is a piece of legislation that we're working hard on. It's got good bipartisan support. It is designed to help address the workforce shortage. It's not just with child psychiatrists either. It's also with psychologists, social workers. We're seeing very high ratios of child-to-child social worker and school psychologist. Unworkable ratios. I mean, school mental health providers who have 513 cases. There is no way that they can adequately meet the needs of these children and families when their caseloads look like that. The second piece of major piece of federal legislation. Now, there's other legislation that the NAMI National Office works on, like parity and Medicaid reform. Unfortunately, I don't have a responsibility for that. That's my colleague. So I'm just going to talk about the child-focused legislation. The Keeping Families Together Act. There is an unfortunate and unthinkable practice in this country called custody relinquishment. And it's actually, what's happening is this directly impacts middle-income families, families that don't qualify for Medicaid, that have private insurance, that have a child with really serious and significant needs, that maxes out of their private insurance coverage quickly because most private insurance plans have restrictive discriminatory caps on mental health coverage, and are kind of left with a, oh no, now what do we do situation. And what's happening in many states, most states in fact, is that the family turns to state agencies that help with children and families, and they're told, you know, there's one way we can get your child services, and that's through child welfare and juvenile justice. Now, that is not the place families want to go, by the way, and sometimes they have to go to court, and sometimes they have to admit to abuse and neglect, even though that's not at all been a part of this family's experience, because that's the only way they can get help. The United States General Accounting Office actually issued a report in April 2003 that documented that 12,700 families in 1 year had to give up legal custody of a child to one of these two systems for the sole purpose of accessing mental health coverage. And actually that was with not all states reporting, and the 5 states with the highest population of children, including New York, California, and Texas, said they knew this practice was a problem in their states, but they don't document an intake list. So they don't have the data to show exactly what the numbers are. So we know this is a very underinflated number. But imagine parents being told, and I'm a parent, and I find that really hard to believe, that the only way you're going to access services for your child is to be able to custody them. It's devastating for the child. It is devastating for the siblings at home. It's a very troubling situation. There's been a lot of talk about integration. How do we integrate? How do we bring physical care and mental health care together? Why do we cut off the body at the head and just treat from the brain down? This is a real opportunity to say, in the context of child visits, that pediatricians are going to begin to talk with families at a very young age to say, how is the mental health of your child? We care about the mental health of your child. We care about your child from the top of their head to the tip of their toes. And so we're very excited about the prospect that this could open a new dialogue. It could help to address stigma. I mean, for families that have no family history and no concerns around mental health, they can hear that primary care doctors care about mental illness and early onset. And we think this is a really exciting development. The other thing we're doing is we're really focusing on schools. And I noticed in the program that tomorrow you have a session on the President Bush's New Freedom Commission report. So I'm really excited about that because actually there was 6 goals that came out of that report. And one is solely dedicated to early identification and assessment of students and the role that schools really need to play in that process. And so I'm delighted to hear you're going to be talking about that. I'm going to talk about that a little bit more in a second. I actually wanted to read this quote. This is actually from the new Freedom Commission report, and I think this is a very powerful statement. The mission of public schools is to educate all students. However, children with serious emotional disturbances have the highest rates of school failure. 50% of these students drop out of high school compared to 30% of all students with disabilities. Schools are where children spend most of each day. While schools are primarily concerned with education, mental health is essential to learning as well as to social and emotional development. Schools must be partners in the mental health care of our children. So this language really excited us because we thought, this is perfect. Now we're going to have a chance to say, we're going to get all the systems where children are to begin to look at children differently. And there's a lot of concerns out there about labeling children, and I think this is very legitimate. And I for one, think that there's nothing worse than labeling someone incorrectly. But I think that equally as bad is not labeling, as I'll use that word in sort of quotes here, is not identifying the child. Because what happens is these children get labeled, all right. They get labeled as bad and poor academic performers and dumb. And I will tell you, I've had so many parents respond to the labeling issue because I think folks in the general public who don't necessarily deal with mental health on a regular basis as we do are very concerned about labeling. And we often have to remind them that, labeling with anything, by the way, any illness, any sort of condition. But labeling is going on with these children, and we don't like the way it's happening. So we recognize that we don't want schools to become the mental health treatment system. That would not be a good outcome because schools have enough on their plates. I think the idea of locating mental health services in some schools would be a very good thing. And we do have mental health professionals in schools. We have school social workers in some schools, we have school counselors. But at a minimum, schools should be developing a link to the community mental health system. So that, and also, through education and exposure to what mental illness is and what early onset looks like, there's much more a likelihood that a school professional that sees a child that's struggling might see that child differently and say, I think this child may really need an assessment or an evaluation. I need to talk with the family. I need to talk with a school mental health professional. We really want to see this type of activity increase. So our goal is to build partnerships with schools and to say, what can we do together? Not to look at them in a judgmental way and say, you're doing such a poor job with students, look at these dropout and failure rates. But how can we really partner so that we can help you with your limited resources and what you have available to you? I actually work in a community interagency collaboration in Arlington, Virginia, where I live. And I was quite surprised. We have school professionals that sit on this coalition that we have formed. We have community mental health providers. We have pediatricians. We have the public health department. And I was quite surprised at how little communication there is between the schools and the community mental health system. So that even, and also the hospital, there's one state hospital that treats children in the community, and when a child is discharged, that child is simply sent back to school. There is not sort of this, how are we going to transition, how are we going to work together, how difficult is it going to be for this child to go back to school and back to the circumstances they were in. And so building communication around how can we do that more effectively. Because what ends up happening is families are often left holding back. And they feel as stressed out as ever when they have to sort of figure out how to best transition their child back into the schools. We actually have a publication called Parents and Teachers as Allies, which Joyce Berland, again, who wrote Family and Family, some of you know that program, hopefully most of you do, she wrote in 1999, and as usual, Joyce was ahead of her time because what she said in there is that schools really need to be partners. She said much of what was said in Goal 4 of the New Freedom Commission report. But what we thought made a huge amount of sense, and a lot of these ideas have come out of the NAMI grassroots organization at the state community level, was why don't we build an in-service? School professionals get in-service on so many other issues. There is no reason why they shouldn't get an in-service on better understanding mental illnesses in students. Not because we would ever want them to be diagnosticians. We don't want them diagnosing. We don't want them talking about medication. That is not the role we think school professionals should play. But we certainly want them to know what early warning signs look like. We want them to better understand a student who may be in distress. And we want them to understand how to effectively communicate with families. There is a lot of shame and blame, as I'm sure many of you know, and families are continue to be blamed. I remember David Kaczynski said this morning, back in the 60s, mothers and parents, and well, that still goes on, and I still get those calls, and I'm really shocked by it, because I always want to think that we're beyond that, but it still happens, and it's unfortunate, and parents are still getting blamed. So this publication is really designed to help them better address school professionals how to effectively communicate with families. So we got this idea, why don't we go out there and develop an in-service program? And we actually approached the foundation, and we said, how about you fund it? And they said, okay, so we have a 5-year grant to develop a program. It's called Parents and Teachers as Allies. It is designed to go through the publication we've developed with parents and a panel of parents, a parent, a school professional, a consumer, and a facilitator who can kind of go through the publication, talk about the early warning signs. The parent talks about what it means to live with a child that has mental illnesses, some of the joys, some of the challenges. The consumer, and the other thing we focus on is the positive. Is what is it that schools have done that have really made a positive difference? Looking at this from a strength-based approach. To say, how did that make a difference in that family's life? And the consumer piece is very important. We usually, for this program, we have a consumer that's had early onset who can talk about some of the negative things that happened in their school experience, but some of the positive things that happened as well. And it reminds me of Bill McPhee, who talked about the Martha in his life. I saw this presentation done for an in-service, and the consumer on the panel described a teacher in her life that really touched her in a very deep way, and it made a huge difference for her. And she had been told, you're not going to amount to anything. She has schizoaffective disorder, very pretty serious illness. Things had not been going very positively in her school experience. And this school professional really recognized that she had a talent in her ability to write, and she really helped her to foster that and made an enormous difference. And you could really hear a pin drop in this audience when she did this presentation. And then at the very end, she read a piece she had published in the newspaper in her community about something completely unrelated to mental illness, but it was very skillfully written. She had gone on to get an undergraduate degree and a master's level degree in writing and journalism, and she was really pursuing her dreams. And she talked about how this one school professional at a fairly young age had recognized her talents and her abilities, and what a difference that had made in her life. So we have developed this program. We had our first national training of trainers for it in March of 2006. We have rolled it out in multiple states. The first state that we did it in was Florida, in Orange County, which has the 12th largest school district in the nation. And the NAMI leader who had worked to develop a relationship with the school said the first time she went to the school and said, I'd like to do an in-service on mental illness. They said, no way, you're not going to bring that information to our school. And it literally took her 2 years to build a relationship of trust. And first she was trying just to get the publication in. So it took her 2 years to convince the special ed coordinator actually for the whole school district to allow her to bring the publication in. And then she built on that into an in-service. And she said the first time she did the in-service, the school professionals literally were following her to her car. And they said, this is really important information. We love the idea that you gave us information about the lived experience. We thought the consumer piece was incredible and very powerful. It was sort of a mini in our own voice. It was really saying, this is our lived experience. This is how school professionals can make a difference. And so we piloted it in several states. Now, I also want to mention that our NAMI Minnesota leader, Sue Beverholm, who's the executive director, took it a step further and thought, I think it would be great if school professionals were required to have in-service training as part of their recertification process. So she actually worked with the autism group, and she got the support of the teachers union in her state, and they went to the state legislature, and they passed this law. It's a very short law. I'd be happy to share it with anyone who's interested. And now, as part of the recertification process, all teachers must have training, and NAMI Minnesota actually does the training. And it's been very well received. So in an innovative way to sort of get more information into the schools in terms of recognizing the early warning signs. I want to leave some time to talk, because I really like that idea, and I hope that people have some comments and ideas of how things might look in Montana in terms of some of the things that have been mentioned in some of these programs. On the state legislative front, we don't work a lot at the state legislative level and on the national office unless we get called in and we get asked to provide some technical assistance because we have such wonderful state folks that work at the state level. But lately, in the last couple of years, we have seen a tremendous amount of anti-psychiatry activity. And this has really become increasingly concerning to us. Much of this really sprung out of the new Freedom Commission report. So the new Freedom Commission report came out and said, and included as a model program, a Columbia University Teen Screen program. And this whole idea of sort of screening kids young, getting those that may be at risk, not for diagnosis, just identifying students that may be at risk, getting them identified and into treatment. So this was one of the recommendations in the new Freedom Commission report. The Columbia University Teen Screen program was featured as a model program. Well, that created this sort of tremendous backlash, and it was fed by a lot of anti-psychiatry groups who said, oh, schools are going to diagnose children, they're going to throw them on these dangerous mind-altering medications, we're going to drug America's children. A lot of misinformation about what the new Freedom Commission report called for. All of this done without parental consent, and we're stripping away family rights, and there's sort of we're seeing more of this kind of anti-psychiatry activity. Much of this is being fueled by organizations who don't believe mental illnesses are real, that don't believe anybody gets mental illnesses. Children, adults, don't recognize, think all medications for children are wrong, that have really preyed on some of the Food and Drug Administration reviews of certain medications for depression and ADHD. And so we are increasingly seeing this kind of, and a lot of this is really preying on fears and stereotypes and myths, and really, we think, driving up stigma. So we have begun to build some coalitions, stronger coalitions at the national level, with provider organizations, with family advocacy groups, to really go out and help educate. Not to say all medications are great for kids and this is an important thing, but to say, first of all, that's not what the new Freedom Commission called for, by the way. That, parental consent, parental involvement is essential to all treatment. That we are concerned about the lack of research on medications for children. That we'd like to see a whole lot more of it. But it's not easy to get families and children recruited into research studies, and we've seen that across the country. It's a very concerning issue. That we are concerned about kids being put on medication, but we are also deeply concerned about the reality that for some kids, medications have meant the difference between life and death. That for some kids, it's meant the difference between participating in school, having friends, being part of their family, staying at home, not being in hospitals. But we'd like to see more activities around research and more information for families about what these medications do, what their risks and benefits are, what the long-term safety concerns may be, and so forth. So really, we want to start sort of a national dialogue to move us away from this anti-psychiatry rhetoric and get us more grounded in what do we need in terms of research? What does good clinical practice look like? A lot of this is the reality that our healthcare system gives us 10 minutes with our provider. Okay, but that is so conducive to giving out medication. Here's your 10-minute visit. Okay, you're on your way, next. I mean, that is what our medical practice is increasingly becoming. And we need to say, whoa, when kids get put on serious, any kind of medication, whether they're getting cancer treatment, diabetes treatment, or treatment for a mental illness, we need to have good clinical practice, close monitoring, good communication with families, helping to educate families about risks and benefits, and so forth. So really, all this to say, we're working at the state level because we've seen some concern in anti-psychiatry child bills, and so we're working to help educate state legislators as well. I think I said all that. But I think really the stigma is a huge concern. I mean, we talk about stigma all the time. And we've seen tremendous advances in understanding treatment with children. I mean, we have a long way to go, but we've seen a lot of good studies, good solid studies. With psychosocial interventions, and a lot of kids get psychosocial interventions, and they really work. So we need to really focus on, it's not just about the medication, it's bigger than that. And that we don't want to see any additional barriers that may keep children and families away from the right treatments. We are also working on building a family network on evidence-based practices, and I have a there's a session after this that's going to really focus a lot on this. But there's a lot of talk, and I don't know if this is happening in Montana, it's happening in a lot of states around we need more evidence-based practices. What does that mean? And families really often don't understand what the evidence-based practices for children's mental health are. And in many ways, I think the movement is moving forward. And I think families have not necessarily been a part of that movement in helping to move more effective treatments into practice. So we have a new MacArthur grant at the NAMI National Office to focus on helping to educate and raise awareness with families about what evidence practices are, about gaps where we don't have evidence-based practices and we need more, so we can help be part of the advocacy machine that gets more evidence-based practices for certain illnesses that children get. First thing we're doing is developing a family guide, and actually the day I get back, on Monday, October 30th, we have a stakeholder meeting with the other national child groups, the National Mental Health Association and Federation, the Georgetown University Technical Assistance Center for Children, and several other groups. SAMHSA is involved in this, to come together and say, what should our family guide say? We already have proposed categories, and how are we going to really educate families so they know what kinds of treatments to ask for, how they should talk with their providers about treatment and safety and effectiveness and long-term treatment, and how long should I expect my child to be receiving this treatment, what kind of benefits should I see, when should I know if the child's slipping? I mean, there's a lot of opportunities for families to learn more about these interventions. And I'm going to talk more about it in the next section, actually. I think the second part of this slide, we are really focusing on closing the gap. And David Kulinski actually touched on this as well. I think the second part is the lag between discovering effective forms of treatment and incorporating them into routine clinical practice is about 15 to 20 years, which I just think is astounding. And that's actually from the Institute of Medicine report that came out in 2002. And to think that we are developing these effective interventions, but then it takes us such an enormously long time to get them out is really troubling. And when I look at some of the ways systems work, I mean, I'm not an expert on all systems by any means, but I really understand the complexity. It takes a lot of political will for change the way practice is done. It takes an enormous amount of leadership. It takes an enormous amount of training and supervision and fidelity and commitment to change. And it's not easy. And there are several states that are doing this now, that are saying we want to focus more on evidence-based practices. And they have found it's a tremendous amount of work. So I don't want to minimize how difficult it is, but we can certainly do better than 15 to 20 years. And again, we think educated families and consumers can help close the gap. That's the purpose of our project, to say, families know a lot, but in the child mental health area, it can be very confusing. There are a lot of confusing messages about what really works. And a lot of what's been developed in academic centers has not been translated well for families to understand. So we want to help with that process in the NAMI National Office and across the NAMI organization. In terms of, and I wanted to sort of summarize what families really want in terms of, and I know there are a lot of families in the audience, and I don't profess to speak for any of you, but I just, in my experience, I get to travel around the country and I get to talk with a lot of families, and I do hear a lot through email and phone calls and, what they really want. And I think this is a very fair list. This whole idea of early and accurate identification. We have so many NAMI folks that say, oh my goodness, I knew something was going on a long time before anything was done. And I think this is a complicated fact. I think we all kind of want to, as I think David Kulinski again said this morning, your first reaction is total denial. There's nothing going on there, my child is fine. You don't want to accept that any illness, that it could be a mental illness. That's probably the least type of illness you ever want to imagine yourself having. But really, we can do a better job in many of the child service systems. In pediatrics, and pediatricians are more than willing to admit that they can do a far better job. In schools, and families really need support. I think families need to understand it's okay to talk about these things. It's okay to think about these things. and we need to do a better job of that. Effective interventions. The MacArthur Foundation a few years ago did a study that showed about 70% of kids get interventions that have not a scintilla of evidence to support them. So they're getting interventions that may or may not be effective. And that's when there are interventions out there that we know are effective. So that's pretty concerning. So really effective interventions is key. And then respect and recognizing the role that families play. The families really are the experts on their children and what has worked and what won't work, and often don't feel listened to. So I think this whole idea of we need to really listen to families and respect them, even when they are in a crisis. I mean, I will tell you, I was at a meeting at the American Academy of Child and Adolescent Psychiatry. It was a bipolar consensus conference. And one of the child psychiatrists there made the mistake of saying in front of a family member, a mom I know whose daughter has very serious bipolar disorder, that, oh gosh, some of these moms are like, oh my gosh, they're just out of control and really difficult. And she turned to him and in the most gentle way, and I thought the most effective way, she said, I've had times when I haven't slept for 3 nights because my daughter is suicidal, and I need to protect her, and I need to protect her siblings, and I need to protect other family members, and I am literally out of my mind because I haven't had sleep, because I am under such enormous pressure, and I am in no way in a position to speak effectively with my child's treating psychiatrist. And I really want you to understand that this is what many families that have children with serious illnesses experience. And it's unfair to judge them in terms of their parental ability. Now, this is not to say there aren't situations out there where there are families, where there are parents that may be doing things that are not very healthy for the family. That is definitely going on out there. And actually, this is not an area that I focus on, but I'm happy to see there's more looking at and trying to better understand how to support families when a parent has a mental illness, and how to support families when a parent is living with an addiction disorder, and how to support families when they're struggling within the family with a lot of socioeconomic issues. So, I think we have a tendency to sort of say, oh, that family is, dysfunctional, instead of looking at it as how can we really help that family, and how can we wrap services around the whole family. And that child may be in distress. Maybe we need to look at the broader picture in a positive and strength-based way. So, let's see. Accountability for positive outcomes and quality improvement. That really, we think, comes with not just the evidence-based practice movement, but I think everyone wanting to be a bigger part of moving youth to resiliency and adults to recovery. Really wanting to be part of a movement that's going to make things better for everyone. Access to full and comprehensive array of integrated and coordinated services. What we see when we look at some states, and actually I'm going to show a slide on North Carolina in the next session to show where we spend our money. We spend a lot of money when you look at the state budget and where money's being spent on institutional care. We don't tend to spend a lot of money in many states on home and community-based services. And yet this is where we're seeing some of the most effective outcomes, is really wrapping services around the family. And I think it's really troubling that and often it's that there aren't a full array, a comprehensive array of services available in the community, that most services are either, come into the clinic, come into the hospital, come into the partial day, come into the residential treatment center. There is not more sort of innovative home-based services that may be very effective for families. So really, we're seeing a lot more interest at the state level in the states that I've actually talked with to build a more effective array of services, but we need to see more of that. Okay, now I just want to talk quickly. I'm sorry, I said I would leave time for discussion. I really want to do that. There are good positive things happening, as I said before. There is the Systems of Care grant that SAMHSA operates. I'm not sure if Montana has had a system. Yep. Okay. How many do you have? This one. Okay. So that the child service folks know about the Systems of Care. It is really an opportunity to build just those home and community-based, more school-based, court-based, more comprehensive array of services. It's a very effective way to do it. What I think to be just a little bit critical of the Systems of Care program What I think they haven't necessarily done well is I don't think they've provided really strong technical assistance to help communities understand how to translate this better into statewide reform. There is more focus on this now, but this program's been around for a while. And I think there's a lot to learn about how to translate it into the bigger picture. There are child and adolescent mental health and substance abuse state infrastructure grants. I know Montana doesn't have one of those, but those are another way. And hopefully, when these states get these federal grants and build good model systems, and we push SAMHSA on this, because this is another SAMHSA program, we always say, please share that information with the states that don't get those grants. That's what we need. We need to be able to translate that into more effective services across more states. The other thing I'm really excited about, I know Montana applied for this, so I'm really excited about that, is the Deficit Reduction Act, which was part of the very large Medicaid reform, and I don't know, probably no one in this room read the whole bill. I think it was 600 pages. I didn't do so. But there was definitely a beacon of light in there, and that was an opportunity through the Center for Medicare and Medicaid Services to have a demonstration project that would allow states to move youth being served in psychiatric treatment facilities out of those facilities and into home and community-based services through the Medicaid program. So it's kids who might not have otherwise qualified for Medicaid based on their income levels, but on their clinical level of need, they could qualify for home and community-based services. So 10 states are going to get this grant. 17 states applied. Montana was one of those states, yay, which I think is great news. And I have my fingers crossed that Montana is one of those states that gets the grant, because I think it's a great opportunity to really build a more comprehensive service system. Now, this is a demonstration project. We had said to Congress at NAMI for many years, you need to change the Medicaid statutes, because when it was written for kids that were in hospitals. And so kids are not being served in hospitals anymore. Many states have closed their children's hospitals. They're being served in residential treatment centers. We need to be able to move those kids out of residential treatment centers into home and community-based services and allow them to maintain Medicaid coverage. And Congress said, no, we can't do that. It's going to cost too much money. So this demonstration project is a first step. And what we are going to do when it's over, it's a 5-year grant cycle. I think it's 5, maybe 6. 5, okay. We are going to go back to Congress. We hope to see really positive outcomes, and we're going to say, see how well this worked. Please change the Medicaid statute. So we have a lot of hope that that's going to happen. The other thing I really wanted to say, and I know this is never easy, but I think we have to really raise our voices on children's issues. I think we really have to say, for those of us who have children that have mental illnesses, these are real illnesses. And you as our legislators, and you as our state legislators, as our federal legislators, we want you to better understand what we as families are living with and why we need effective services, so that we can do a better job of advocating for more money for the children's mental health folks that are sitting in the room here, to build more effective systems. And I think we have a responsibility to educate and inform lawmakers who often hear from the anti-psychiatry folks and don't as often hear from us. Because we really need them to hear from their constituents about how we need more investment in effective service. And I know NAMI's done this extraordinarily well on the adult side. And I just want to encourage all of us to do a better job on the children's side. I said these are 3 things you can do. I just thought, well, I want to make it proactive, and I want to leave people with an idea of what can be done. And I really think, or if you see a news clipping or something that you want to send to your state legislator, I mean, it really is about building a relationship so they understand what the lived experience is and what is critically needed. The other thing is to meet with schools. In our experience, schools, they may be a little reluctant because they're often overwhelmed. And when I go to my children's school, there's so much activity and chaos, frankly. I wonder how they get done when they get done. And there's so much pressure to cover so many things, but They really do care about these issues. I am convinced of that. And I think we need to make sure they understand and make it a priority. I don't think they know that national leaders in the mental health movement are calling on them to be partners in helping to identify kids and link them with the mental health system. So really kind of building a relationship so that they understand and asking what we as partners can do with them, how we can build our alliance. And then get to know the data. I think nothing makes a more compelling argument for change. I mean, school failure, suicide, juvenile justice crisis, the amount of money we spend on kids. We had a series we did at the National Office a few years ago called Spending Money on the Wrong Places. And really, that is what we're doing. We are waiting till kids get into the deep end. We are spending money in juvenile justice. We are spending money in suicide attempts and hospitalizations and emergency rooms. And really, we need to be spending much more money on the front end. And I am a firm believer that although we have to make an investment in administrative change, we will see way better outcomes on the back end.